Meeting call to order.
I request President Rotarian Hemlata Bhandari ji to please confirm the minutes of the previous meeting.
The minutes of the previous meeting were circulated on the group, and I hope everyone has read it. And since no queries and questions were raised on the same, the minutes of the previous meeting stands confirmed.
Thank you so much, President. Good evening, namaskar. आप सभी का रोटरी क्लब ऑफ ऑर्गन डोनेशन इंटरनेशनल की इस मीटिंग में बहुत बहुत स्वागत है। आज का टॉपिक है रोल ऑफ ब्रेन डेथ कमेटी इन ऑर्गन डोनेशन। ब्रेन डेथ कमेटी का क्या रोल रहता है ऑर्गन डोनेशन में, और इसके लिए हमारे बीच बहुत ही एमिनेंट गेस्ट हैं डॉक्टर पूजा त्रिपाठी, MBBS, DNB, DM Neurology, Senior Neurologist, former member of Brain Dead Committee from Lucknow. तो बहुत बहुत स्वागत है आपका, और मैं रिक्वेस्ट करूंगी हमारी इमीडिएट पास्ट प्रेसिडेंट रोटेरियन PHF रितिका गुप्ता जी से टू गिव द इंट्रोडक्शन ऑफ द गेस्ट। हमारे आज की अतिथि का इंट्रोडक्शन दें।
Thank you very much, Secretary Rotarian Ruby Agarwal. It is my utmost pleasure to be reading out the introduction of our chief guest and speaker for today, Dr. Pooja Tripathi. Dr. Pooja Tripathi is an MBBS, DNB, DM Neurology, Senior Neurologist, and former member of the Brain Death Committee at Lucknow. She has extensive experience in diagnosing and managing a wide range of neurological orders with a special interest in pediatric neurology, stroke management, and movement disorders. Dr. Tripathi completed her DM in neurology from King's College Medical University, KGMU, Lucknow, where she was honored with the prestigious Stuti Nag Gold Medal as the best DM student. Earlier, she also received a gold medal in MBBS, reflecting her consistent academic excellence. She previously served as an assistant professor at KGMU and RMLIMS and worked as a neonatal and pediatric intensivist at Artemis Hospital, Gurugram, gaining valuable expertise in pediatric critical care. She is actively involved in clinical research, has presented scientific papers at leading national neurology conferences, and is a member of the Indian Academy of Neurology, the Indian Stroke Association, and the International Movement Disorder Society. Today, Dr. Tripathi will share her insights on the role of Brain Death Committee in organ donation, highlighting the medical, ethical, and the legal aspects of brain stem death certification and its crucial role in enabling life-saving organ transplantation. Ladies and gentlemen, please join me in extending a warm Rotary welcome to Dr. Pooja Tripathi. Welcoming you, Doctor.
Thank you so much, and it was overwhelming to listen my introduction. Thank you so much.
Thank you so much, IPP Rotarian PHF Ritika, for the introduction, and over to you, Dr. Pooja.
Is my screen visible?
Yes.
Yes. Please make it full.
Put it on a slideshow.
Yeah. So,
yes.
Good evening, everyone. Today, our topic of discussion is brain stem death certification in organ donation. As you have already beautifully illustrated my introduction. So let's start the topic. So today we'll cover the topic of brain death in following points like definition, historical background, Transplantation of Human Organ and Tissue Act 1994, which was amended in 2011 and further in 2014, declaration of brain death, determination of brain death, and special consideration. So what is the concept of brain death? So death is defined as either irreversible cessation of circulatory or pulmonary function or irreversible cessation of all function of whole brain. So basically in brain we have part, the most important part in our brain is brain stem, which is responsible for all vital activities in our body. So the irreversible cessation of all function of the whole brain, including brain stem death, which means a brain death. Brain stem is responsible for our respiration, our cardiac activity, and by all the means why we are living. So determination of death must be made in accordance with accepted medical standards. So irreversible loss of entire brain, including brain stem, with complete loss of, how will diagnose the patient is having severe brain damage by his or her consciousness, certain brain stem reflexes, and independent capacity for ventilatory drive, that the person is able to breathe spontaneously or with support, or not. Certain neuroendocrine functions. So our brain is very important for different hormones which are secreted by our pituitary gland, which is the smallest little gland in our brain. So neuroendocrine function may persist in patients with irreversible injury to the brain and brainstem. And there are certain ancillary tests which serve as a surrogate means of assessment. So it is the definition given by American Academy of Neurology of brain death, which was updated in 2010 as well, because previously there is no in brain we have cortex, brain stem, so they have not given that much importance to the brain cortex or cerebral cortex. But in recent amendment, they have given the cerebral cortex, severe damage to cerebral cortex can also lead to brain death. So concept of brain death, irreversibility refers to the impossibility of recovery regardless of any medical intervention. That should be there. There should be no reversibility. And we should differentiate brain death from other forms of severe brain damage like vegetative. A certain patient may remain in the vegetative state for years and minimally responsive state. So there should be irreversibility, and we should differentiate from vegetative state and minimally responsive state. So certain cases of we have seen cases of organophosphorus poisoning or sulfos poisoning, snake bite, and these are the cases which can mimic the cases of brain death. That is why the irreversibility is very important. So what is the history of establishment of brain death criteria? In 1959, it was first theorized as Lee coma de passe by Mollaret, and which describes an apneic, that means there's no breathing, and comatose patient without brainstem reflexes or EEG activity. In 1968, Harvard came into picture and they revised the criteria into Harvard brain death criteria. In 1980, there is a Uniform Determination of Death Act legal basis of a neurological determination of death by the US. In 1995, finally, American Academy of Neurology had put forth guideline on the determination of brain death. That has been revised in 2011, and there are some amendments in 2014 as well. In 1987, the American Academy of Pediatrics also published the criteria of brain death in children. So there is a Transplantation of Human Organ Act, which is a 1994 act. This act's purpose to regulate the removal, storage, and transplantation of the human organ. Act was amended in 2011, and brainstem death is recognized as a legal death in India under this act since 1994. So let's start the topic. Till here there is a history, why there is a brain death, how does it came into picture. Now, who can declare, that a very important topic, who can declare the patient is brain dead? So there should be at least 4 persons. The hospital administration should be there, like in government medical college, there is a medical superintendent, a resident doctor of the hospital who is seeing the patient, neurologist or neurosurgeon or physician, intensivist and anesthetist, and treating doctor. So initially it was like no, that neurologist should be there, but in the 2011 Act, apart from if there is a non-availability of neurologist or neurosurgeon, anesthetic, critical care specialist, intensivist, physician, or surgeon can include have been included to facilitate brain death declaration. That is amendment in 2011, and further there is a specification in 2014 as well. So brain stem death certification is a 4-step method. So step 1, first we have to decide why there is a brain death, prerequisite of brain death certification. Step 2 is examination of the patient. Step 3 is confirmation of which we the finding we have examined in step 2. And step 4, the ultimately is obtaining consent for transplant of human organ. So the step 1, that is determination of brain death. So there are prerequisites that there should be a etiology why the patient is in this state. The evidence of etiology of coma should be known. There should, that I previously in previous slide also I have highlighted, that there should be no reversibility. That is the most important factor. The core body temperature should be 36 degrees centigrade for at least 24 to 72 hours. The blood pressure should be or equal to more than 100. There are certain parameter of sodium, serum osmolarity, calcium, glucose, and ABG plus alcohol. In certain condition in alcoholic poisoning as well, there could be a mimic of brain death. So the alcohol quantity in the blood should be less than 80 milligram per deciliter. So the most common cause, however, in our India is brainstem death is trauma, post-traumatic cases. So it's very important. Then step 2. Step 2 is examination of a brain dead patient. First, we have to physically examine the patient. Is patient is responding to the pain? And there are certain brainstem reflexes which we have to see. In step 2, there are actually 3 major things. First is physical examination. Second is very important apnea test. That is the core test for brainstem death certification, and certain ancillary tests if the apnea test fails. So in physical examination, there is motor response to by giving pain, is there is any responses or not. There are certain reflexes which we have to see in case of brain dead patient, like light reflex, corneal reflex, certain brainstem reflex, that's called vestibulo-ocular reflex, caloric test, and doll's eye movements we have to see, gag reflex, cough reflex. These are the reflexes we have to see in detail before confirmation of brain death. Apnea test, which is very important. Most of the patient with this state, with comatose stage, used to have a ventilatory support. So in apnea test, basically in brain stem, there is a part called medulla, which is responsible for our respiratory drive. So absence of respiratory effort in presence of hypercarbia or acidosis, there is a test which we called as ABG, arterial blood gas. We used to withdraw the sample from the patient blood and see the CO2 level, carbon dioxide level in his or her blood. So there are a certain prerequisite in who can perform the apnea test. The temperature should be at least 36 degree. The blood pressure should be fine. There should be no the CO2 with ventilatory support should be 35 to 40 in the ABG, which I have mentioned. Blood pH should be normal. So these are the prerequisites for apnea. Apnea test is very important for declaring brainstem death. So there is a procedure which we have to follow while doing this test. And if there is a fall in BP while performing apnea test or fall in SpO2 while performing it, we have to abort immediately. And in this case, we have to take the support of ancillary tests. There basically 3 tests are mentioned in our textbooks and in the act as well. That is DSA, digital subtraction angiography. With this, with the help of this test, we see the blood vessels and flow of the blood in the brain. Then there is a radionuclide imaging. With the help of tracer, we will see the blood-brain barrier. And there is a Doppler. Like Doppler, we see in our veins and flow of the blood vessel. Similarly, we have to do the Doppler of brain. That is called transcranial Doppler. So these are ancillary tests. So after doing the step 1 and step 2, after examination, after this etiology rule out, and after performing the exhaustive tests, the step 3 is confirmation of the brainstem death. All the procedure which we have done in step 2, all prescribed tests are required to be repeated after minimum interval of 6 hours to ensure that there has been no observer error and persistent of clinical state can be documented. We have to repeat the whole procedure after 6 hours. A positive second test, that means the patient is declared as a brain dead. For a dead patient, for a brain dead patient, according to the Act, we have to fill this Form 10. Form 10 is specifically the brain stem death certificate as per the THO rules 2040 has to be filled. Then in my clinical scenario, in my clinical experience as well, sometimes there is like the family gave the consent for organ donation. But sometimes there is a, if a patient is declared brain dead after the second test and the relative now, initially they are saying, okay, we are fine. But now they are not giving the consent and they withdraw the consent for this key. We are not ready for the organ transplantation and we are not ready for the same level of the treatment, because you need to know and you need to focus that after second test, which we are repeating after 6 hours, the patient is dead. This is clinically brain dead patient. But our Indian law do not permit for a ventilator to be disconnected, and the ICU team is liable for ventilating it is a technically dead patient in such a scenario. So in this case, to these type of problems, the Act also suggested that counseling and consent of organ harvesting be taken without any ambiguity before a second test, before a second brainstem death testing. In a case of, is there is an ambiguity or they are like, we don't want to do we don't want to go for organ transplantation, then the second BSD test, that is a brainstem death, should be withheld and patient should be managed accordingly by not escalating the therapy. So after there is a legality after the second test, the patient is officially brain dead. So ventilating in these are very common scenario in a government hospital, in a private hospital. So step 4, that is also very important. Finally, agar hum step 3 tak aa gaye hain with a successful remarks, then there is a step 4, obtaining consent for transplant of human organ. Obtaining from consent we have to take from next of kin, matlab nearest closest relative, or presence of a transplant coordinator is a mandatory for declaring brainstem death under this Act 2014. At least 2 personnel should be trained as a transplant coordinator by NOTO, who will be responsible for obtaining consent. And the another very important point is the team of the doctor who manage the patient and the team of the doctor who are part of the transplantation cannot be the part of the counseling group. This is very important. Transplant coordinator is a different entity which are involved with the counseling regarding the transplantation. And in this case, the doctors who has managed the patient and doctor who are going to transplant, these are not in this counseling group. So determination of brain death, certification of brain death. In USA, only 1 apnea test is fine. In UK, 2 apnea tests, second test can be done anytime after normalization of blood gas after the first test. But in India, that is very mandatory. We have to perform the second test after an interval of 6 hours. Time of death also varies. Time of death, according to American Academy of Neurology, time when PaCO2 reaches its target value during second apnea test is a time of death. And after confirmation of post-ancillary testing, if we require. Thank you so much. This is all.
Thank you very much, Dr. Pooja. Please close your presentation.
Yes, sir.
Yeah, thank you very much. You have given a very elaborated description about the Brain Death Committee, which is really very enlightening to all of us. Dr. Pooja, before I will open the forum कि सब questions पूछना शुरू करें, मेरे दो
Yes.
क्वेश्चन थे आपसे. पहला
जी.
क्वेश्चन ये है कि जो आपने बताया कि न्यूरोलॉजिस्ट का रिक्वायरमेंट है, ये पहले इंडिया में था कि कंपलसरी था कि एक न्यूरोलॉजिस्ट होना जरूरी है, चाहे न्यूरोसर्जन हो या न्यूरोफिजिशियन हो. बाद में एनेस्थेटिस्ट और फिजिशियन और सर्जन वगैरह को इंक्लूड किया गया. क्या यही रिक्वायरमेंट यूएस से यूके में भी है कंपलसरी, या वहां भी इंडिया की तरह कोई भी रह सकता है?
Sir, I think in Western country, there is a requirement of neurologist and neurosurgeon. But in India, because of the less availability of super specialization in government setup, they have amended in 2014 that a critical care specialist or anesthetist or a general surgeon or a physician can do this certification.
Okay. Secondly, you said about 6 hours minimum interval in India.
Yes,
why this 6 hours? Why not 5 hours? Why not 7 hours? Is there any specific thing about this 6 hours?
No, sir. The thing is that in UK, you can perform as early as possible after the normalization of. There is a test which we called the arterial blood gas sample. So in UK, there is like if the CO2 becomes normal within 1 hour or within 2 hours, you can perform the second test. But in Indian setting, they are saying ki, at least we should give a 6 hour gap for normalization, because apnea test itself is a it's a hard test for the patient as well. We have to disconnect the ventilatory tubings from the patient end, and what we are seeing is the patient is able to maintain the blood pressure, and is there is any drive for respiration, what we are seeing in the apnea test basically. So if the patient is brain dead, there is no spontaneous respiration, and the CO2 will rise. It can rise up to 100 or it can go up to 180. So for normalization, for performing second test, the CO2 should be within the normal limit. The blood pressure should be more than 100 without any vasopressor support, sir. And vasopressin, like the drugs which we require for maintaining blood pressure. So in Indian society, they are saying that at least it will give for 6 hour time for after the first apnea test, so that the patient is in a in vitally stable.
ओके, थैंक यू वेरी मच. अब मैं खोल रहा हूं अपना सब, जो इसको भी क्वेश्चंस पूछने हैं अपने को अनम्यूट करें, अपना हाथ उठाएं. मैं देख लूंगा स्क्रीन पे, एंड देन आई विल अलाउ देम टू आस्क द क्वेश्चन. जिसको भी पूछना है, प्लीज अनम्यूट योरसेल्फ. यस, आई कैन सी रोटेरियन प्रोफेसर डॉक्टर सुधीर सरन. यस, प्रोफेसर सुधीर सरन, योर क्वेश्चन प्लीज.
Thank you, Dr. Pooja. It was very elaborate and fine distinctions between different stages in a very important part of thing. Now,
Thank you,
how can we explain 100% error-free decision of brain death?
It is, sir, it is a observer error. That is why we are performing the second test after 6 hours. And it's a basically the certification of brainstem death is dependent on the neurological examination, like brainstem reflexes, and there are certain test like ABG, so that we can see the CO2 level and ventilatory setting. And for performing error-free, the examination team should be well aware of the brain stem reflexes. From a neurologist point of view, sir, in my clinical experience, the most important thing is brain stem reflexes, like corneal reflexes, vestibulo-ocular reflexes, caloric testing. These are the most important tests. If the patient is fail in these tests, I think 99.995% we can say, yeah, the patient is brain dead. The observer variation is there, but the brain stem reflexes are the paramount important. And apnea test also, there's a co-test for brain stem death.
Okay.
Thank you.
Thank you very much, Professor Saran. Dr. Pooja, as you आपने बताया कि इससे error free and कभी आज तक मेडिकल हिस्ट्री में ऐसा हुआ है कि आप लोगों ने डिक्लेयर किया, आप मींस द ब्रेन डेथ कमेटी हैज डिक्लेयर्ड कि द पर्सन इज ब्रेन डेथ, लेकिन वो बाद में कॉन्शियसनेस में आ गया या उसको होश आ गया?
No, sir, this is not this case, but I remember one case when I work as an intensivist in Artemis Hospital, Gurgaon. There is a kid who's 12-year-old who referred from some part of rural part of Haryana कि उसको वहां से भेज दिया है कि पेशेंट ब्रेन डेड है, अब इसको ले जाओ, उसका कुछ नहीं हो सकता. Then we received the patient in emergency department, and I was on duty, and I don't know, the first thing my teacher told me कि when there is a loss of brain stem reflexes, the temperature of body थोड़ा सा कम हो जाता है. There is a tendency of the body, and the blood pressure is slightly on the lower side. But the kid is maintaining the blood pressure, and the body is completely warm. And so we thought how the outside party had declared brain, but there is no response. There's no, that is the most important, that is most common, common fallacy in that case, loss of corneal reflex. There's no response to the light in eye. That is very important reflex. So we thought we are overthinking. There is a loss of light reflex. It's a brain dead case. But I don't know. My teacher said me no, I don't think so. When you are saying the temperature is right, everything seems fine, just perform an EEG. We did a EEG, and sir, the kid is absolutely fine. There is a complete, like us, activity in the brain. There is a complete rhythm. So we took the history, and it came out to be case of snake bite, who is mimicking as a brain death. And we started the anti-snake venom, and kid is absolutely fine. And after 3 days, he was awakened, and he's saying कि नहीं, आप सब लोग जोर जोर से CPR कर रहे थे.
ओके डॉक्टर पूजा, इसी में मैं पूछूंगा जब तक कोई और क्वेश्चन पूछने के लिए अपना हाथ उठाता है. अभी रिसेंटली अबाउट 3, 4 और 5 मंथ्स बैक इंडिया में बरेली के एक केस बड़ा हाईलाइट हुआ. काफी मीडिया ने भी उसे उछाला कि वहां से डिक्लेयर किया गया था ब्रेन डेथ, और फैमिली उस बच्चे को लेके जा रही थी बैलगाड़ी में या किसी उसमें या बस में, और वो झटका लगा, सड़क पे गड्ढा था और उस झटके से वो होश में आ गया. अब मीडिया ने उसको बड़ा उछाला भी, हालांकि उसका कोई कॉन्ट्रडिक्शन शुरू में बिल्कुल नहीं आया था, बाद में आया भी है. तो क्या किसी ने उसका ब्रेन डेथ, जैसे अभी आपने बताया कि हरियाणा से रेफर होके आया था, ब्रेन डेथ डिक्लेयर किया था या प्रिज्यूम किया वहां के डॉक्टरों ने, जबकि वहां कमेटी नहीं भी होगी, कि ये ब्रेन डेथ हो सकता है, इसलिए रेफर किया, इसलिए वो होश में आया? आपके क्या व्यूज हैं उसमें?
बहुत ही कैजुअली ना रिमोट एरियाज में ब्रेन डेथ टर्म यूज कर लिया जाता है. दैट आई थिंक वी शुड स्टॉप इट नाउ. कि ब्रेन डेथ इज नॉट लाइक कि आप सबको इस्तेमाल करें. इट्स अ प्रॉपर क्राइटेरिया. कुछ टेस्ट होते हैं, उसके बाद ही हम इस टर्म को यूज कर सकते हैं, ब्रेन डेथ क्राइटेरिया को. यस, इट कुड बी मिमिकिंग केस लाइक सेल्फॉस पॉइजनिंग के केस बहुत मिमिक करते हैं ब्रेन डेथ
Okay.
cases को.
I can see
Snake bite.
Rotarian. Okay, thank you, Dr. Pooja. I can see Rotarian Ramnath Pradeep. He wants to ask question. Yes, Rotarian
Yes,
Pradeep.
Dr. Pooja, good evening. I just wanted to ask, in spite of large number of accident taking place, particularly in India, the declaration of brain dead is very, very less, resulting into the less availability of the organs. Whether there is a intentional the action on the part of the committee of the doctors not to declare the patient as a brain dead, or there is a some sort of because it has to be a consensus decision and everybody has to so the why there is a less number of brain dead being declared in India, particularly
Yes.
when the accident is taking place, lot of other things are happening in the society, everybody knows.
Thank you, sir. Thank you for the question. This is a very important question. I totally agree with your point that certification of brain death is very less in India. And there is a hesitancy, you can say, from the doctors as well. There was. Now there are proper act, proper guideline, so that we can confidently declare the patient as a brain death. Because there are certain legalities, sir. I told you, I explained in a detail that after 6 hours, the main issue happened after 6 hours when we declare the patient is officially brain dead now. And after that, there are two. Suppose that in my practice, there are so many cases of TBM, tubercular meningitis, and when the TBM grades like in grade 4 or advanced diseases, there are chances of brain death because of the irreversibility of the disease. So in that case, we can the patient, the deceased patient, is not applicable for organ donation as well, as he or she is suffering from the infectious disease as well. So in that case, when we start explaining the prognosis to the patient कि नहीं अब बहुत खराब है, चीजें negative ही जा रही हैं, there is always a reluctancy from the patient end. They became aggressive. TBM के पेशेंट जो हमारे पास आते हैं, वो आते हैं सर इन अ वेरी बैड स्टेट. 1 साल से दवाई चल रही है, देख नहीं रहे हैं. जब हमारे पास जिस स्टेट में आते हैं, और व्हेन वी स्टार्ट एक्सप्लेनिंग कि देयर इज अ पुअर प्रोग्नोसिस, तो फिर अब आप छुट्टी करिए, अब आप छुट्टी कर दीजिए, आप वेंटिलेटर से निकाल दीजिए, हमें कुछ लेना देना नहीं. तो उस केस में द पेशेंट टुक लामा, लेफ्ट अगेन मेडिकल एडवाइस, और वो ब्रेन स्टेम डेथ का सर्टिफिकेशन हो नहीं पाता. ब्रेन स्टेम डेथ सर्टिफिकेशन के लिए वी हैव टू फॉलो द रूल्स. व्हेन वी स्टार्ट एक्सप्लेनिंग देयर इज अ पुअर प्रोग्नोसिस कि देयर आर लेस चांसेस ऑफ रिवर्सिबिलिटी ऑफ द डिसीज, फिर सर इंडिया में सिनेरियो ही कुछ और हो जाता है.
Okay.
But this is a big problem. Do you agree that this is a big problem, not getting the organs?
Yes,
When in
it
spite
is
of
a
the
big
thing,
problem, but we
there is
have
a
to
pressure
raise.
from the family of
Yes,
the
sir.
the
We
deceased
have to
not to
raise
declare the patient as a brain dead. Because you have been working in the bigger hospital, so there is a possibility of more pressure from the family of the brain dead person not to declare the person as a brain dead.
There are
There is a pressure.
they used to say कि डॉक्टर साहब और थोड़ा वेंटिलेटर, keep ventilating the patient, keep continuing the treatment what we are doing. When we declare the brain dead, there are a hesitancy कि नहीं अब हमें सारा अंतिम संस्कार proper से करना है, and there is a misconception also कि जो organs अगर हम दे देंगे तो अगले जन्म में भी without उसी organ. These are the common myths the patient relatives usually have. So breaking
How do you remove this misconception or myths
sir,
from the patient? Because you deal with the patient, you deal with the
duty of
family of the
transplant.
patient.
That is duty of transplant coordinators. That is why Noto उन्होंने सेक्शंस बना दिए हैं कि द डॉक्टर्स विच आर ट्रीटिंग द पेशेंट दे आर नॉट आर द पार्ट ऑफ द
Committee.
counseling
makers.
for do not over involve emotionally with the patient basically. So there are transplant committee that is different, transplant coordinator are different, and removing that myths in India is it's still we are very far.
डॉक्टर पूजा, जो डॉक्टर रामनाथ प्रदीप का क्वेश्चन था एक्सीडेंटल ब्रेन डेथ के लिए, एक्सीडेंटल जो केसेस हैं, आज इंडिया में जो डेटा अवेलेबल है कि करीब 1,80,000 एक्सीडेंटल डेथ्स होती हैं पर ईयर। उसमें एक प्रिजम्पशन है या एक ऐसा अनुमान लगाया जाता है कि करीब 50% ब्रेन डेथ हो सकते हैं अगर उनका ब्रेन डेथ कमेटी असेसमेंट करे। द प्रॉब्लम इज द इंफ्रास्ट्रक्चर। हमारे यहाँ ब्रेन डेथ कमेटी अवेलेबल ही नहीं है इंडिया में। जब ब्रेन डेथ कमेटी नहीं है हर डिस्ट्रिक्ट के अंदर, जहाँ पे रिट्रीवल सेंटर्स ही नहीं है, तो वहां तो असेसमेंट होता ही नहीं है। तो अब जो आप असेसमेंट करते हैं वो कुल 15-16% डिस्ट्रिक्ट हेडक्वार्टर्स में, जहाँ पे रिट्रीवल या ट्रांसप्लांट सेंटर्स हैं, वहीं पे आप असेसमेंट कर पाते हैं इंडिया में। तो जो 84-85% पॉपुलेशन है जो एक्सीडेंट हो रहे हैं, मेजर एक्सीडेंट्स हो रहे हैं हाईवेज पे या जहां भी हो रहे हैं, रोड एक्सीडेंट्स की मैं बात कर रहा हूं, वहां पे तो असेसमेंट होता नहीं है। तो डोंट यू थिंक कि जो आपकी जो कमेटी है वो खाली मेट्रोज और क्लास ए सिटीज को ही सर्विस दे पा रही है, या कभी आप लोग छोटे सिटीज में या विलेजेस में या ऐसे जगह जाते हैं जहाँ पे एक्सीडेंट बहुत होते हैं, डेथ बहुत होती है हाईवेज के आसपास, ट्रॉमा सेंटर्स में, लेकिन वहां आपके यहाँ ब्रेन डेथ कमेटी नहीं है? इस बारे में कुछ आप बताना चाहेंगे? कभी आपके कमेटीज में ऐसा डिस्कशन हुआ या नोटो या सोटो में इस बात पे आया कोई बात?
सर उसमें तो बिल्कुल आपका पॉइंट बिल्कुल सही है कि जो रिमोट एरियाज हैं, जो ये जो डिस्ट्रिक्ट लेवल के एरियाज हैं, वहां पे इतने एक्सपर्टीज अवेलेबल नहीं है। बट जो अभी हमारे पास अवेलेबल है 15-16% भी जो आप बात कर रहे हैं, अगर हम उसी को टारगेट करें वी कैन डेफिनेटली मेक द डिफरेंस। वो भी अभी 15-16% भी अभी हम लैग कर रहे हैं।
वो तो बात आपकी सही है, लेकिन प्रॉब्लम क्या है कि जो से 15-16% जो डिस्ट्रिक्ट हेडक्वार्टर्स हैं, लाइक दिल्ली, मुंबई, बेंगलोर, चेन्नई, कोलकाता, वहां पे ट्रैफिक इतना स्लो चलता है सिटीज में कि वहां के जो रोड एक्सीडेंट्स हैं उसमें ब्रेन डेथ के चांसेस बहुत कम होते हैं। ब्रेन डेथ के चांसेस होते हैं, जैसे अभी आप आगरा में थी, इससे पहले आगरा के आसपास कहीं भी, सॉरी, अच्छा, आगरा
हाईवेज पे ज्यादा होते हैं।
हेलो, is anyone saying something?
PDG Lataji is saying something.
हाँ, yes, PDG, what you want to say? अच्छा, सॉरी। तो अभी जैसे आप आगरा में थी, तो आगरा में के आसपास कहीं भी रिट्रीवल सेंटर ही नहीं है, ट्रांसप्लांट की तो बात ही छोड़ दीजिए। तो वहां पर जो ब्रेन एक्सीडेंट्स हो रहे हैं, क्योंकि हाईवेज जो बने हुए हैं वो सब इसी तरह की सिटीज के आसपास ज्यादा हैं, वहां बहुत रोड एक्सीडेंट्स होते हैं। तो उनके कमेटी, वहां पे कोई कमेटीज फॉर्म की गई हैं, ब्रेन डेथ कमेटी, या ऐसा कोई आपको जानकारी है?
सर मुझे आगरा का तो इतना एक्सपीरियंस नहीं है। आई वाज देयर फॉर 1.5 मंथ ओनली। बट केजीएमयू जहां से मैंने डीएम किया है, वहां पे स्टेट का सबसे बड़ा ट्रॉमा सेंटर है। सो वी आर
केजीएमयू मींस लखनऊ,
किंग जॉर्ज मेडिकल यूनिवर्सिटी। यस सर,
लखनऊ।
सो ट्रॉमा सेंटर है वहां पे। एंड मतलब आई कैन नॉट टेल यू, मतलब बहुत ज्यादा रेफरल केसेस आते हैं, ट्रॉमा केसेस आते हैं, बट स्टिल अगर आप ये समझ लीजिए कि 50 पर पेशेंट ट्रॉमा का पर डे फुटफॉल होता है, तो उसमें से शायद केजीएमयू के 3 ईयर के पूरे मेरे टेन्योर में शायद 1 या 2 पेशेंट होंगे जिन्होंने कॉर्निया डोनेशन के लिए एग्री किया था। तो सर डेफिनेटली रिसोर्सेज की कमी है, बट हमारे पास जितने रिसोर्सेज हैं अगर हम उन्हीं को यूज कर लें, एक अवेयरनेस पहुंचाएं लोगों तक कि मिथ से ज्यादा ऑर्गन डोनेशन की तरफ जाएं, वी कैन डेफिनेटली मेक अ डिफरेंस। अभी भी
Okay.
हमारे पास बड़ी बड़ी सिटीज में बहुत सारे ऐसे ट्रॉमा, आप एम्स दिल्ली ले लीजिए, सफदरजंग ले लीजिए, इतना ट्रॉमा है कि मतलब सर बहुत ज्यादा केसेस है।
जी, thank you. Now, PDG, you want to ask? Yes, you have raised the question, your hand. Question पूछिए अपना, unmute करिए please अपने को. PDG Lata, yes.
This is more a duty of the social workers, as I have been in Rotary and worked with lot of hospitals at one time. What I feel that this exactly is the work of the social workers. जैसे आप बोल रहे हैं वहां पे नहीं है लोग देखने के या बताने के लिए, डॉक्टर पूजा जो बोल रहे हैं, सो वहां पे सोशल वर्कर्स जो होते हैं, दे आर ऑफ अ ग्रेट हेल्प टू फर्स्ट ऑफ ऑल टू कन्विंस द फैमिली मेंबर्स, क्योंकि पहले तो फैमिली मेंबर्स ही मना करते हैं करने के लिए। जैसे पूजा जी कह रही थी कि अगर आंख निकाल ली तो बाद में अंधे पैदा होंगे, दो सॉर्ट ऑफ सुपरस्टिशंस आर देयर। So that is the work of the social worker more, क्योंकि डॉक्टर जो बोलेगा वो पेशेंट नहीं सुनेगा इतना, क्योंकि वो सोचता है
Definitely.
वो उनके उनके मतलब की बात है तो उनको
बात।
निकालनी है तो उनकी बात नहीं सुनेगा। डॉक्टर समझता है पेशेंट के पेरेंट्स रिलेटिव्स नहीं निकाल के देंगे बिकॉज दे आर इमोशनली इन्वॉल्व। सो द बेस्ट पर्सन यू शुड हैव इज अ पर्सन हु इज इंडिपेंडेंट ऑफ बोथ।
PDG अभी इसमें एक प्रॉब्लम ये आया था.
Absolutely agreeing with your point. That is why Noto, they came with the beautiful concept of transplant coordinator. They उन्होंने
So who is
sections
a
कर दिए.
transplant?
Transplant coordinator usually either a nursing superintendent or they have on regular basis. They have meeting from the Noto and they have their counseling session, how to counsel the patient for organ donation and all, because they are not directly related with the patient party.
So another thing was Mr. Goyal, what he was saying that these centers don't have a facility for donation. He was saying. So
Yes.
isn't it कि अगर छोटे जगह पे हो, so then they are taken to a metro city or something for doing
No,
this thing?
no, PDG, it is not possible because किसी का पेशेंट का ब्रेन डेथ पहले तो डिक्लेयर ही नहीं होगा वहां अगर ब्रेन डेथ कमेटी नहीं है, और उसको अगर हो गया डिक्लेयर तो हाउ इज इट पॉसिबल कि वो 150 किलोमीटर दूर ले जाएगा ऑर्गन्स डोनेट करने के लिए, वापस फिर 150 किलोमीटर अब बॉडी को वापस लाएगा उसको क्रिमेट करने के
ये
लिए.
सेंटिमेंटल
और
चीजें हो जाती है, नहीं तो उसको वहां पे भी आप कर सकते हो, बट
नहीं, अच्छा,
these are where
दूसरा
the
नहीं,
sentiments
वो
come
बहुत
in.
दूसरा जो अभी आपने एक पॉइंट किया उसका मैं क्लेरिफिकेशन दूं डॉक्टर पूजा, आई वुड लाइक टू ब्रिंग टू योर नोटिस आल्सो. कुछ जगह गवर्नमेंट ने अलाउ किया था सोशल वर्कर्स को टू कम एंड कन्विंस द टू एक्ट एज ए कोऑर्डिनेटर, लेकिन उसमें पाया गया कि जो सोशल वर्कर्स हैं उनके अपने इंटरेस्ट, सेल्फ इंटरेस्ट ज्यादा थे और उन्होंने कुछ चीजों में इंड्यूसमेंट देना शुरू कर दिया रिलेटिव्स को कि अगर आप ऑर्गन डोनेट करेंगे तो आपके रिलेटिव को सर्विस मिल जाएगी गवर्नमेंट की, आपको इतना रुपया मिल जाएगा, आपको ये बेनिफिट्स मिल जाएंगे, विच इज नॉट, इट्स टोटली इलीगल एज पर. तो इस वजह से गवर्नमेंट ने अभी मेरी मीटिंग हुई थी सोटो राजस्थान जयपुर में, तो उन्होंने कहा ऐसे में प्रॉब्लम हुई, हमने उन लोगों को एक जगह भी दे दी थी अपने अंदर जहाँ पे ये डिक्लेरेशन कमेटी वगैरह होती थी, पर बाद में उन्हें हटाना पड़ा क्योंकि उन्होंने गलत प्रोमिसेस किए थे. तो जो आप कह रही हैं, इसीलिए जो कोऑर्डिनेटर्स हैं वो गवर्नमेंट वहीं के हॉस्पिटल की अथॉरिटीज होंगी, नर्सिंग सुपरिंटेंडेंट हो या सोशल वर्कर का रोल वहां पे बिल्कुल नहीं हो सकता और होना भी नहीं चाहिए, क्योंकि सोशल वर्कर जो है उसका सेल्फ इंटरेस्ट होता है या अपने टारगेट्स
करप्शन भी
पूरा
होता
करने के
होगा,
लिए वो
करप्शन।
सब. हाँ जी, यस, तो इस वजह से वो पॉसिबल नहीं है. Thank you very much, PDG Lata, for raising the questions. Anyone else wants to ask the question? If anyone has any questions, please unmute yourself and raise the question. I will. Yes, I can see our immediate past president, Rotarian PHF, Ritika Gupta. Yes, please ask your question.
Yeah, so Dr. Pooja, thank you so much for sharing your insights through the presentation. I wanted to ask you, so when you actually declare it to the family, have there been instances of like assessment of the brain death situation because of family's insistence, or usually when you declare it, it's the final say, or there is some unrest that is caused due to the family of the deceased?
Okay.
So usually we don't do that. We just follow the protocol. That is a 4-step protocol, and to the re-examine the patient after 6 hours, that we used to follow. And after 6 hours, if the findings are remain the consistent, we declare the patient as a brainstem dead patient. If the apnea test fail, then we'll take the help of ancillary testing that I explained, the digital subtraction angiography, radionuclide imaging, or transcranial Doppler. If
Okay.
everything goes smooth, we don't usually revisit the diagnosis.
Okay. Okay. Thank you,
Okay.
doctor.
Thank you very much. Any other questions? I think आज का जो टॉपिक है काफी टेक्निकल है, एंड बट यू हैव एलोबरेटेडली उसको जिस तरह आपने एक्सप्लेन किया है, काफी कुछ
इमोशनल भी है, टेक्निकल भी है और इमोशनल भी है, दोनों
नहीं,
चीजें।
इमोशनल तो देखिए मेडिकल में हर चीज इमोशनल है, देयर इज नथिंग विच इज नॉट इमोशनल, लेकिन बिकॉज ब्रेन डेथ कमेटी के बारे में बहुत कम बताया जाता है, बहुत कम
जानकारी
एक्सप्लेन
कम
किया
है।
जाता है, विच इज वेरी मच इम्पोर्टेंट। जब मेरा डॉक्टर पूजा से बात भी हो रही थी तो मैंने कहा ब्रेन डेथ कमेटी एक ऐसी चीज है जो, क्योंकि ये लोग फ्रंट में नहीं होते, ये बैक स्टेज वर्कर्स हैं, तो इसलिए बहुत जरूरी है कि ये लोग हमें बताएं, एक्सप्लेन करें कि क्या चीज है, क्या करते हैं और क्या इनका रोल रहता है। और आपने जो एक पॉइंट बताया कि अगर पेशेंट के रिलेटिव्स मना कर देते हैं आफ्टर द फर्स्ट ब्रेन डेथ टेस्ट, then you are not performing the mandatory second test for the brain death, and then the patient relatives के ऊपर है वो कब तक वेंटिलेटर को चालू रखना चाहते हैं, till the time they can afford, they can keep the ventilator on, और जब नहीं होगा तो अपने आप वो तो
This is the and sir, this is the most common scenario in Indian setting. This is the one of the most common scenario. Yeah.
अच्छा, जैसे अपने और जगह ऑप्ट आउट सिस्टम है, अपने यहाँ ऑप्ट इन सिस्टम है, तो आई एम टॉकिंग ऑफ कंट्री लाइक यूके और यूरोप, देयर आफ्टर वंस द कमेटी डिक्लेयर ए पर्सन ए ब्रेन डेथ, क्या उसके बाद रिलेटिव्स का रोल रहता है, या यू जस्ट इन्फॉर्म the coordinators will inform the patient relatives कि see the patient has been declared brain death, now because the organ belongs to the country or the state, we are just informing you, और उसमें भी उनकी पूरी कंसेंट ली जाती है?
After the second test, if we certify the patient as a brain dead, we used to inform the patient party that the patient is brain dead. Now there is no reversibility for the condition, and if everything goes smooth and the patient party is willing for organ donation, then the transplant coordinator explained regarding the this donation thing. If the patient is not fulfilling the criteria for organ donation, like the patient is suffering from some infection disease, HIV, tuberculosis, and so other causes, then we can remove all the life support system, and we can certify that the patient is brain dead, that there's no reversibility. And if they are willing for organ donation, then we have to keep the patient, maintain the monitor, maintain the endocrine function of the patient. The patient will remain on the ventilator with the full support care, with the full critical care, and we have to maintain the vitality of all the donated organs.
Okay. Yes. Dr. Pooja, apart from the brain death committee, now as a neurologist, is there any chance with the advancement of the medical science, the artificial intelligence, etc., that we will fix this brain death phenomena by transplanting or by inserting some chips in the brain, and so that the brain death, the patient will come out from the brain death?
No. Sorry, sir. Yeah.
Dr. Pooja?
Yes.
Have you heard my question?
Yes, sir. You have said, is there any chance for transplantation in brain? basically
Yeah.
you are
like putting some chips, जैसे अभी एलन मस्क का भी चल रहा है कि वो ब्रेन में
that
चिप्स
is a
लगाने का.
gimmick, sir. That is a gimmick.
Sorry, Dr. Pooja.
That is a gimmick, sir. Do you think that neurons works in like that easy way? That is a gimmick, sir.
Okay.
So neurons have they are very susceptible. The basically the cell body of the brain is called neurons. So they are very susceptible for the oxygenation, for the blood flow. So if the blood supply of the brain hamper for seconds, the 10 million neurons can die in a fraction of second.
Okay.
So the thing is that once there is when there is a irreversibility in the neurons after certain age, we cannot revive them.
Okay. Okay. Thank you very much. I can see Rotarian Deepan Shah. Rotarian Deepan Shah, are you there? Yes, Rotarian Deepan Shah. Just unmute yourself. First of all, accept happy anniversary to you and Rotarian Jigna Shah. You are celebrating your anniversary, 35th anniversary this year in USA. Yes, Rotarian Deepan Shah, you are driving car also there. Yes, you have any question to Dr. Pooja?
No, wonderful. First of all, thank you, Mr. Goel. A wonderful topic about brain neurology and brain death. Now, I don't have any questions, but I have one hope regarding Elon Musk drive about the neural link. I have a hope. What I read the article, so time will tell. Yeah. So that's it. Wonderful. Thank you so
Okay.
much.
Thank you very much, Rotarian Deepan Shah. Yes, any other question anyone wants to ask, or shall I hand over
Close the
back?
meeting.
Yeah, PDG, you have any question?
No.
Okay, thank you. So now over to you. I think Rotarian, sorry, Dr. Pooja has given lots of information to all of us. In case if we have any questions, we will definitely disturb you again, Dr. Pooja. Although now you are not in Agra, now you have gone to Lucknow back, and I have just seen during your site presentation that you have joined the Max group there in Lucknow. Congratulations for that.
Thank you.
And luckily, UP, the problem in the organ donation is that's a very, very backward state, I must say, the most backward in the entire country. With 75 districts, the donation rate is very, very less, very poor. I'm sure now once you are there in Lucknow, the capital, definitely we may see some hope there. Thank you very much. Over to you, Regal Secretary, Rotarian Ruby Agrawal.
Thank you so much, Founder and Charter President Rotarian Lalmanji, to conduct this session. And thank you so much, Dr. Pooja. आपने इतना technically sound और इतना important subject of brain death हमारे जैसे जो क्लब हमारा organ donation पे based है और हमारे सब members को जानकारी दी, उसके लिए आपका बहुत बहुत धन्यवाद और आपने इतना अच्छे से presentation दिया. और मैं अब बुलाऊंगी रोटेरियन डॉक्टर प्रोफेसर डॉक्टर सुधीर शरण जी को वोट ऑफ थैंक्स देने के लिए आज के कार्यक्रम की. तो आई रिक्वेस्ट प्रोफेसर डॉक्टर सुधीर शरण, प्लीज गिव द वोट ऑफ थैंक्स.
Thank you, Dr. Pooja, for making such a difficult topic,
Can't hear.
sensitive one, emotionally charged one, so simple for lay people to understand.
Please be a little loud, Dr. Sharan. Can't hear you.
Okay.
He's I think he's also in USA.
Yes. Thank you, Dr. Pooja, for making a very sensitive and a complex issue so simple for us lay people to understand. Thank you also for answering all the questions. More understanding came through your answers to the difficult questions we posed because our concerns were so high. So we are grateful to you for spending your time and making us enlightened in this matter. Brain death is not a simple matter. There is a lot of responsibility riding on the person who declares. After all, on their decision depends what will happen. So we are thankful to you for this important contribution to us.
Thank you.
Thank you to our respectable members who have spared time to sit here and understand this matter. Human life is precious. We must know there has to be very responsible things, and we understood different angles of the issue. So thank you everybody for being with us, listening to everything, and taking part in this one. Thank you very much.
Thank you.
Thank you so much, Professor Dr. Sudhi Sharanji, for giving the vote of thanks, and thank you to all the Rotarians to attend this meeting. और आज की मीटिंग अटेंड करने के लिए आप सभी का बहुत बहुत धन्यवाद, और जो सभी यूट्यूब पे वॉच कर रहे हैं उनका सभी बहुत धन्यवाद. I request President Rotarian Hemlata Bhandari ji to please adjourn the meeting.
Thank you very much for attending the meeting. Thereby meeting is adjourned.
Thank